Protocol AB is here. What does it tell us about how to treat patients with diabetic vitreous hemorrhage?
I'm Greg Notstein here with Scott Kriswanis, and this is New Retina Radio from Retina Today and Bryn Mawr Communications. Dr. Andrew Antoszyk presented the DRCR Retina Network's latest study comparing two treatments for diabetic vitreous hemorrhage, aflibercept and a combined vitrectomy laser procedure.
Did either option come out on top? Dr. Antoszyk has the answers.
The DRCR Retina Network's protocols have been some of the defining data in modern retina. Indeed, one cannot imagine care of diabetic eye disease without the group's research.
At the 2020 virtual AAO Annual Meeting, that tradition continues. Dr. Andrew Antoszyk is here to outline the results of DRCR Retina Network Protocol AB, which compared aflibercept to a combined vitrectomy panretinal photocoagulation procedure in eyes with vitreous hemorrhage from proliferative diabetic retinopathy.
Dr. Antoszyk is the medical director of clinical research and a vitreoretinal surgeon at Charlotte Eye, Ear, Nose, and Throat Associates in Charlotte, North Carolina, and is the vice chair of the DRCR Retina Network and protocol chair for Protocol AB. Dr. Antoszyk, thank you so much for joining us today.
Greg, thanks so much for the kind invitation. We're really excited about the results of this study. It's been eagerly awaited by the retina community, and the results we believe are going to be very relevant, particularly in the midst of a pandemic.
There are a lot of places to start when it comes to diabetic vitreous hemorrhage. Why did the DRCR Retina Network choose to go down this particular path?
Well, diabetic vitreous hemorrhages are a frequent cause of vision loss in patients with diabetes. In a prior DRCR Retina Net trial, Protocol S, we saw over the course of 5 years rates of vitreous hemorrhage approaching 50%. In eyes that were treated with PRP, this occurred 46% of the time, and eyes treated with ranibizumab, this occurred 48% of the time. It was somewhat shocking to us that there was no well-established guidelines regarding how to treat vitreous hemorrhage in eyes with proliferative diabetic retinopathy. We knew we had two options: vitrectomy, which is the established standard of care since the 1970s, and intravitreal anti-VEGF injections, which can be performed in the office, that stimulate regression of neovascularization and prevent rebleeding while the vitreous blood is reabsorbed.
So, what exactly did the DRCR Retina Network compare when assembling Protocol AB?
So we wanted to compare two treatment strategies: intravitreal aflibercept injections versus prompt vitrectomy with panretinal laser. And the goal of our study was to determine which resulted in a better mean visual acuity outcome over the course of 24 and 104 weeks.
The DRCR Retina Network is a notoriously collaborative bunch. How many sites did this study have altogether?
Well, as you know, this was a randomized multi-center clinical trial, and it involved 39 sites around the country. We enrolled patients with type 1 and type 2 diabetes who had vitreous bleeding in one eye due to proliferative diabetic retinopathy, causing visual impairment of 20/32 to light perception. And then we randomly assigned them in a one-to-one fashion to either intravitreal aflibercept therapy or prompt vitrectomy with panretinal laser.
What endpoints did the investigators look at in this study?
The primary endpoint was average visual acuity over 24 weeks. That is, looking at vision over this time period, which we label as area under the curve analysis. We did have some secondary endpoints, which were individuals that required treatment with vitrectomy that had been initially randomized to aflibercept treatment, as well as the individuals that were randomized to vitrectomy requiring aflibercept treatment during follow-up.
I see. And how many patients are we talking about altogether?
Well, we enrolled 205 patients, 100 patients in the aflibercept group, with 90 remaining in the study at 2 years, and 105 patients in the vitrectomy group plus PRP, with 87 remaining at the 2-year endpoint.
What happened in the follow-up period?
During the course of follow-up at our primary endpoint, which was at 24 weeks, we found there was no difference between the aflibercept arm and the prompt vitrectomy plus pan-retinal laser group. We set our margin at 8 letters, and we only found a mean difference at that point, area under the curve, of 5 letters. But what we found was that a third of the individuals in the aflibercept group had to undergo vitrectomy plus pan-retinal laser, and almost all of them had at least one additional aflibercept injection over the course of 2 years, with the mean number of injections over this 2-year time period being 8.9. On the flip side, 1/3 of patients in the vitrectomy plus pan-retinal laser group needed aflibercept injections, and they averaged 2.3 injections over the course of a 2-year period.
Let's talk about vision at 24 weeks and at 2 years. What did you and your colleagues find?
We found at 24 weeks no statistical difference in mean visual acuity letter score between the aflibercept and vitrectomy group, and this also persisted out to week 104. However, patients in the vitrectomy plus pan-retinal laser group had a quicker recovery of vision at 4 weeks. They gained, on average, 2 lines of vision, a mean number of letters of 11.2. And this was significant, but this difference evaporated by week 12 with a mean difference of only 4.5 letters favoring vitrectomy, which was not statistically significant at that point. We looked at patients who achieved good visual acuity at 2 years. That was defined as 20/32 or better. And this occurred in 62% and 68% of the aflibercept and vitrectomy eyes, respectively. So we also looked at patients who achieved poor visual acuity at 2 years. That's defined as 20/200 or worse, or legally blind. And this occurred in 3% of the aflibercept patients and 11% of the vitrectomy plus pan-retinal laser groups.
Any safety concerns that we need to be aware of?
We did see in the aflibercept group a higher rate of retinal detachments, which were predominantly tractional in nature, 23% compared to 14% in the surgical group. Most of these were tractional, as I stated. And in the aflibercept group, these were identified at or just before the first visit when the vitreous hemorrhage cleared enough where we could visualize the retina, or they underwent vitrectomy, whichever came first. And this was in 13% of the eyes, and then 9% thereafter. In the vitrectomy group, tractional retinal detachment was identified primarily at initial vitrectomy in 12% of the eyes, and less than 1% of eyes thereafter. Other safety parameters that we looked between the two groups were equivalent, and in particular, there was no imbalance of APTC events such as heart attacks and strokes.
What's the upshot of Protocol AB?
Although there was no significant difference in mean visual acuity letter score over 24 weeks, eyes that had initial vitrectomy with pan-retinal laser had faster visual recovery, reduced recurrent hemorrhages, and greater resolution of neovascularization than those receiving aflibercept. Long-term vision after 2 years was similar between the two groups. Over 2 years, 1 in 3 eyes assigned to aflibercept received vitrectomy, and conversely, 1 in 3 eyes assigned to vitrectomy required aflibercept. So in this era of the pandemic, both aflibercept and vitrectomy with PRP are viable first-line treatment options for patients with diabetic-related vitreous hemorrhages.
Dr. Andrew Antoszyk, thank you so much for joining us today.
Thank you for having me.
Thank you so much for listening to this special edition of New Retina Radio. Make sure to subscribe wherever you get your podcasts.
If you feel up to it, leave us a review on Apple Podcasts. It helps with those algorithms. That's all from us. Bye for now.